I'm Dr. Allan Perel, and this is Conversations in Medicine. I'm Dr. Allan Perel, and this is Conversations in Medicine, a program that brings cutting-edge medical topics to the Staten Island and tri-state community. Welcome. Today's topic is dementia. Sometimes we think about dementia and Alzheimer's disease being the same. They're really not. Dementia is a more global term for people who have got global cognitive impairment with memory, judgment, orientation problems. And Alzheimer's disease is one specific type of dementia. Sad to say, over 40% of people at the age of 85 will develop some form of dementia. Medicine is going forward, medical science, in order to try to find a cure, better treatments than what we have. But until we do, there are so many people with our aging population that need services for dementia. This is both the caregiver, the care partner, the family members, and the patient themselves. So I have a wonderful group here today, experts in the field, to really enlighten us on what services are available both on Staten Island and the entire tri-state community. So my guests, I'll go from my left to right. This is Neshama Marcus. She's a social worker at LMSW. She works and runs multiple programs at the JCC and some very innovative programs for people with early dementia in order to try to keep them doing well. What we've learned from a lot of medical studies is one of the things that we try to do is tell people to keep mentally active. Just like if you went to the gym to build up your muscles, doing mentally stimulating activity helps keep the brain good as long as possible. And that's so important. And next here is Brian Danaker. Brian is the Executive Director of the Staten Island Agency for Alzheimer's Disease and Dementia. He's a wonderful guest, and we've known each other well, and a tremendous resource to my practice being a neurologist and for all the people in the tri-state area in Staten Island.
Thank you.
And to my immediate left is Susan Klein-Perel, LCSW. She works at the MS Center of Staten Island. She's done a tremendous amount of work in the geriatric psychiatry field at the hospitals. And she's in private practice. And in addition, she's my wonderful wife. So welcome, welcome. I'd like to start with some things about what services are available. And when we talk about services, how do you divide up, and I'll go start with Brian for a moment. How do you divide up services that you provide when someone calls you for the family and patient?
Well, it really depends on what their needs are. We first listen to them. In a lot of cases where their first go-to, because when they first get the diagnosis or an inkling they need to get testing, they'll come to us. And I look at my organization as the quarterback of Staten Island. We have wonderful people on the island, such as the JCC, that we refer to and look at them as a partner. We have other groups that deal with support groups, and sometimes people need legal services or financial services and referrals. And it's very hard to have it all in one place. So what we like to do is help them understand what they want, sit down and talk to them, and get them the individual services they need from the best people that can provide them. Particularly like for the early onset stages of Alzheimer's, they have some great, wonderful programs at the JCC. You have ACT, you have our support groups on Tuesday, you have some care facilities that they may need to look at for long-term care. So whatever those needs are, we like to assess them, sit down and understand them, and most importantly, listen. And that's probably one of the biggest things that people need, is they need somebody to listen to them and then understand what they want and then get them what they need.
So it sounds like getting in touch with someone like yourself, some of the other people on our panel, early is always better. Waiting till there's a crisis is not such a great thing.
And particularly in the financial side of things. Unfortunately, with the financial side that we often deal with, the quicker you can deal with, the earlier that you can deal with the financial side of it, the less stress goes on later on, and you can focus on what is the key, which is the well-being of the person that is inflicted with the disease. So it's important that you deal with as many of the ancillary things as possible so you can focus on care.
Neshama, tell us about your program a little bit. You have a very innovative program at the JCC. It's for people with early dementia. Tell us what's different about it than, there are a lot of senior centers around, and there are a number of my patients who go to a lot of the senior centers. They have lunch, there's some music, there's some things out there, but what makes the program so unique? I know I'm on the committee that works with you guys with that, and we have a number of our patients we've referred, and we've really tried to think about your program in a very different way than others. So please tell us about it.
Sure. So the JCC provides support to both the individual who has dementia, often Alzheimer's, but not only, and also their family caregivers. And the important thing is to see them as a family system. You can't help the person who has dementia without helping the family caregiver. So in terms of individuals who have dementia, we have what's called Rosemary's Place, which is our early stage memory center. So we recently received funding through Richmond County Savings Foundation to provide support to individuals who are recently diagnosed with Alzheimer's disease and related dementias. And I'd say the largest component of that program is a support group. So a lot of people think that robust programming, which we have, is what drives a program, but really it's having a network of support for individuals who are recently diagnosed.
So if someone comes in, if someone calls you or Brian, and Brian refers to your center, tell me a little bit about what would they expect the first day they go to the JCC? What would they see?
Sure. So most people have art therapy, music therapy, and like I said, innovative programming, mind wellness activities to keep the mind sharp and engaged, and always some type of fitness component because hand-eye coordination, cardiac stimulation is all very, very important. But the goal, like I said, is to engage the individual with dementia to understand their needs, to understand how they can be active in their care plan and long-term care planning.
Susan, I'll ask you, as a physician and neurologist, most people with dementia will eventually come to see a physician. It could be the geriatrician, it could be their internist. And what I do as a neurologist who deals with a lot of people who are seniors or with cognitive issues, we do a workup. We test your memory very formally. There's certain kinds of ways that we do that, both between me and the patient, and then me with using certain computer devices, neuropsychological testing, to assess where they are. We'll use imaging, like an MRI or a CAT scan, to see what's happening, and do a blood work and a number of things to see if there's something reversible in this process. Particularly if someone comes to my office, I know there's a real problem. People don't want to spend their day hanging out of my office. It's a nice place, but it's not so nice. What role, and we work as a team, what role does the social worker have? Everybody knows you go to your internist, you get blood work, you go to the neurologist, he'll do a test or two or evaluate you and maybe start you on some medicine. But there's so many of the patients that I have that I refer to you, and they do so well as a group, and as Neshama was talking about, the family therapy. Where does the social worker come in with this?
So, as you were saying, that when a patient who has signs or symptoms of dementia comes into your office, you kind of instinctively know there's a problem. The family probably does also, and that's why they're there. They're bringing them to you. And I think the luxury in our office is that we're there from the beginning because we know that this is a process and this is life-changing, and it changes the configuration of families, and we try to provide support from the beginning right through diagnostic testing, because we know we have a sense for there's going to be some results that will need action taken, and we're trying to assess all the way through levels of support that the family's going to need, what kinds of financial supports, figuring out we'll have to send them to. There are the whole fields of elder care attorneys that early on we try to, it's a lot at once for the families, but we try to sort of sort out what the priorities are, what they need, how things are functioning at home, any medicines, and sort of gently work them through each appointment and give them tasks that will help them through the next step, whether it be medicines or programs or financial sorting out to help them have more support either in the home or with other resources, and always keeping an eye on the family to see who needs what, because it's a stressful thing to accept that somebody you love is dealing with dementia. And I just want to also say it's not necessarily only somebody elderly or a parent. We see younger and younger people with these kind of challenges. So that's also, we had a case recently where a woman in her 30s came in with her mom in her 50s, and she knew that there was a problem, and you subsequently diagnosed them And that's another set of challenges. So trying to just support people through the whole process at different stages of life. It's more prevalent than people realize, and it's also could be devastating.
And absolutely. And as you said, some people ask me when they come to the offices, how do you know the first day someone has dementia? And the answer is you don't. There's a lot of in between. So I think about this as normal, and then someone with dementia who's having functional disability or problems. There's a big gray zone in between, and we use the term MCI for that, mild cognitive impairment. And Brian was very much alluding to that a few moments ago. If someone feels like they've got some memory problems, orientation problems, judgment problems, not doing well, even if you don't make a formal diagnosis of dementia, and that's good not to, there's still issues that have to be addressed by the family,
Correct.
including healthcare proxies, things that might happen in the future. And people with that entity called mild cognitive impairment have about a 15% chance per year of going on to have Alzheimer's disease or even a different kind of dementia. Our practice is somewhat unique in that we see so many patients with different diagnoses, as you mentioned. People with MS can have dementia. People with Parkinson's disease can have dementia. People with Huntington's disease. People who have traumatic brain injuries. And I'll go back to Neshoma's program. You don't have people in our audience, and we have a wonderful group of people who watch us all the time, they're saying to themselves, if my mom or dad or brother or sister doesn't have Alzheimer's disease, are they eligible for these programs? I mean, Brian can, of course, give general information.
Sure.
Susan can help with families. But again, you have something very substantive. You have a program. Does that program allow for people, say, with multiple sclerosis and cognitive problems, Parkinson's disease and dementia related to that, or some other disorders? Do you have to have a diagnosis to be able to get into your program?
Sure, good question. So I would say no, they don't have to have a diagnosis of Alzheimer's disease or even related dementia. If there's mild cognitive impairment, of course we accept them into the program. I think what's most important is that you want to make sure that it's a good fit. So if somebody's coming to the program that has Parkinson's, I think that they would want to be in a network of support of individuals that also have Parkinson's or experience similar symptoms. So if we accept them into the program, we want them into the program, and we love having them. But we also want to make sure that they're developing a network of support. So we would refer to other organizations that provide that nuanced, service.
I mean, that's a very good point that, you want to make sure that you're with the right group because
Right.
they need to receive the proper service. And we often get referrals for other conditions, but we're lucky enough to be able to do the research and get them to the proper group here on the island or within the tri-state area. It's very important that they are with the right group, which is why we partner with as many people as possible.
So tell us a little bit, Brian, about, we want to get into some substance.
Sure.
So someone comes in, there's a relative of mine who's got cognitive impairment, and they call you up. I've given them your phone number.
Yeah, many times.
And please announce how would someone reach you. I'd love to hear that.
Sure.
And do you have a checklist? I mean, Susan was mentioning different things that are being done. Is there actually a checklist that you go over? And as I said, let's go over some of the substance, whether we're going to an attorney, whether it's finances. How do we get from here to there?
Yeah, what we do is we have a generalized conversation, which we have some points that we take them through. We start with trying to get to know the family, some of the history, how long it's been diagnosed. We want to make sure that they're seeing a proper physician, that it's, that you want to make sure it's a neurologist or someone in the field that's related, and it's not and nothing against a general physician or a general practitioner, you just want to make sure that it's, they're specialized. So you get the proper diagnosis and the proper medication if there needs to be. And then we try and understand if there's proper financial planning, there's legal documents in place, or wills, or healthcare proxies, which...
So tell us about them. Let's go a little slower.
Sure. So, yeah, I'm old. I love it. So one of the main focuses that we go through is we want to make sure that they have a healthcare proxy in place. That's
Which
very
is?
important. So someone can make the proper decisions on behalf of the patient. Because in all actuality, you know as well as I do, Alzheimer's patients or people with certain conditions, not that they put on a certain face when certain people are around, but they tend to act very much more normal. So when they have to go to an ambulance or there needs to be a intervention as far as the healthcare side, if you don't have that proxy in place, they have rights, and you cannot make the decision on their behalf and will not be able to get the proper care for them.
So how do you get a healthcare proxy?
Well, you work with your attorney, or we refer them a lot to CASC, which is the Community Age of Senior Citizens here on the island. They're wonderful. We have a number of attorneys that we refer them to, as well as some other social workers. It depends on how much of the services they need. So, for instance, if they need more than just the legal services, we may turn them over to your wife, because they deal with the follow-ups and the individual care and just outside more of just healthcare proxy. But a wider range of services. We'll refer to someone that can help govern that a little bit finer than just a legal service can be. So we also make sure that we want to see what their home life is. Do they have people that can be there 24 hours a day, 7 days a week? Do they have proper, are they eligible for a home health aide? If not, are they able to go to a JCC program or an ACT program or some of the other Friendship Center programs that are out there? So we go down the list of certain things that we feel that they can go and are eligible for, and we start getting them in touch with the proper folks, and we then like to follow up with them throughout the process. But it's very important that they understand they're not alone, that this is something that they don't go through alone. We have support groups during the day. The JCC has wonderful support groups that because not everybody can meet during certain times, so it's important that we have a wide array of support groups. And it's important that the family members get there because they are going through this disease as well. So it's important that when we meet with them and go through the checklist, we ask how they're doing as well. You know, where are you at? What do you need? Because often they need just sometimes somebody to talk to. They just need a outlet for their, and a lot of times, anger. Why is this happening? And that's where we try and be the serving of the family side of it, and then make sure that if they're receiving medical care, that they're receiving the right medical care from proper physicians.
And that's so important. I think that there's actually a study out there that the care partner, particularly the spouse, the longevity of someone diagnosed with Alzheimer's disease is about 8 years. In many studies, the spouse does not live as long as the patient with Alzheimer's disease.
It's unfortunate.
And that's because you don't go to the doctor, you don't take care of yourself.
We see this all the time if the care partner neglects themselves. They're under tremendous stress, they're not eating right, they're not sleeping right, they're not taking time to have leisure moments, and they often get quite ill or find out they have devastating illnesses prior to the identified patient.
So
we
I
see this
mentioned
all the time.
Yeah, so I mentioned before that we have a caregiver support center, and the goal of our program is to really enhance caregiver capacity. The goal is to keep, the family member in the community, in their home, as long as possible, to avoid, unnecessary institutionalization. In order to do that, you have to, educate the caregiver and provide them support. So there's an evidence-based program called Powerful Tools for Caregivers. It's a 6-week program geared towards helping them understand the needs of the individual that they're providing care for and how to communicate their needs effectively. Brian mentioned we have support groups. We also have programs that are geared towards we call them joint enrichments, but they're programs for the caregiver and the care receiver, so that way they can participate in, I know you had mentioned that when there's family conflict, it brings up a lot when somebody's diagnosed, and the goal is for them to have time together. So I can't express more the importance of engaging the caregiver and enhancing their capacity and providing support for them so that they can do their job more effectively.
If you just to capitalize on your point, if you look at it from a caregiver perspective, you're getting hit with the disease, you're getting hit with the stress of dealing with the patient, getting hit with the financials, you're getting hit with the legal, you're getting hit with the health proxy. Then you got to deal with the family and all the things that go on with that, and they're getting hit at once. And it's amazing, and that's why the programs that the JCC offers and your wife offers, it's very important that we utilize them and they get that help.
One of the things we do when a person is diagnosed and they're with a caregiver, care partner, is we always take a few minutes with the person on the side and give them a little spiel about you have to take care of yourself. And this is sort of like you have to go to doctors, you have to eat right, you have to take care of yourself. If you need more support, you have to tell people you can't hold this in, this is very stressful. You're going to be making all these appointments and doing all these different things, whether they hear you or not at that moment. At least it opens a door so the next time they come in, after we spend time with the identified patient, we'll go back over to the caregiver. Do you have any questions? How are you? And it sort of like builds that rapport with them to let them know that it's hard and that they're going through a lot.
It's so important that you're doing that, because I know we had recently done a needs assessment on Staten Island to determine the needs of individuals with dementia and their family caregivers. And two of the largest gaps, one was like that people, when they were first diagnosed, they couldn't make the bridge to community-based supports. And then the second one was that they just didn't even hear information coming to
Right.
them.
Right.
So if they were communicated with, with any providers after their diagnosis, they bridged, and connected to community-based supports.
That's great.
Susan, let me ask you a question. One of the group of patients that I refer to social workers, and you particularly, are the families that are concerned whether mom or dad, brother, sister, could be home or in a skilled nursing facility. You run a program at Harbor House, part of Edgar,
Right.
the skilled nursing facility. Harbor House, I believe, is an adult
It's
center,
like an
senior.
assisted living. It's on the grounds of Edgar. I think it's owned by the same company, but it's a completely separate edifice. And we have.
And you
yeah.
tell me about that every
They're-
week when
they're
you're there.
in- Yeah, they're independent.
How
They have their
wonderful
own
the
rooms,
services
right.
are.
And there are
what-
many other places like that on Staten Island.
So the idea that there shouldn't be guilt if someone needs to have some help, whether it's through an assisted living or whether someone needs more help in a skilled nursing facility, how do you help a family come to the reconciliation of where their loved one should go? Should they stay home? Are there services available like home health aides? Something more than people might not be safe alone in the house, whether they belong in a senior or assisted living or whether in a skilled nursing facility.
It really, in social work we have a saying, you start where the client is, and it's really true that there's not one size fits all answer to that. Basically, you bring in resources depending upon the situation. So the first question I always think of is this person really depressed? Is it really Alzheimer's? Is anybody, because we have a big problem with suicide and depression in our society, and we always have to screen for that. And that's something that's always in the back of our mind. And so once we're at the level where we know it's definitely some form of dementia, Alzheimer's, and that we're going to start to need to pull in resources, if there are medical needs, we call the VN, the visiting nurse, or some medical assessment, agency to try to get a sense for what the skilled needs are. Because one thing about Alzheimer's patients and families is they're really good at covering things up. So you never really know, unless you start to ask specific questions or you walk them through their day, what's really going on. Do they know the hot water from the cold? Are they really dressing themselves? Are they really, eating by themselves? Like, you don't really know because everybody's sort of put together when you see them and they look okay. But I've made home assessments where the story is completely different than what presents in the office. So I try to gather. And people are overwhelmed. That your instinct as a family member is to protect. So you don't always want to rat out mom and say she doesn't really know anything what she's doing. You don't, or she soils herself. You don't want. It's humiliating, and so you don't. Especially before you have a good rapport with the family, you don't really know what's exactly going on. So to pull in different assessment tools like I said, a nursing or some nursing assessment to get more information about their medical history, to get an idea, are they isolated? Are they really, you don't know, mom can't really function, or dad, I don't want to focus on
Quality
mom
of life.
in society, right? So are they really stuck home a lot and they're not going out much and they're not socializing? And we try to make sure their life is full still, but in a way that they could function and deal with it, with the diagnosis. So we pull in a lot of different resources, and every case is very, very different. And we also don't like to go too fast with the family. You can only take little bits and pieces of this at a time. So we give them a couple of phone numbers, and whatever the main problem is, that's what we focus on first.
So it's interesting, in my practice and through the world, we talked about people being diagnosed the first day you get your keys or things like that, and that doesn't happen.
Right.
Meaning that you're allowed when we get older, anyone, to forget where you put your keys. It really becomes something like dementia when you cross into a functional decline. Problems at work, problems driving a car, problems doing your finances. Most people who come into my practice or around, as you said, come in at a moderate stage of dementia. Not mild cognitive impairment, but really at a moderate stage using a lot of the things that we look at. And why is that? Because it's the squeaky wheel. If someone is at their dinner table on Sunday and doesn't spit or throw something or say anything outrageous, but just sits in the corner, then nobody pays attention.
Right.
Everybody's so busy in their own life. I think at most people's table, everybody's got their own phones out. And I'm not sure how anybody talks to anyone, let alone seeing who's there. So if someone is not disruptive, everything seems to work out.
Right.
Well, we also look for something flagrant, like does the person's hygiene look somewhat off, not right, or is there a quick loss of weight, or something specific? We look for that, and we try to follow like you say, the squeaky wheel, the thing that seems most relevant at that time.
Some people are lucky enough to have what I call like the nag factor, that if they have
Right.
someone at home that's willing to nag them until they go see a doctor.
Right.
Yeah.
So I think that, I don't know about you, but I think that we experience people coming in a little bit earlier because somebody nagged them.
Especially with early diagnosis. I mean,
Yeah.
almost by definition in that program, especially knowing some things that go with the JCC, people have to be somewhat functional to be involved in your program.
Absolutely.
And I think that's one of those things that are so important. Brian, I'm going to talk about some history with you.
Sure.
Your organization, what was your organization? Well, you took over your organization, and I think we said a story before. There was a wonderful lady who we miss very dearly, Gladys Schweiger,
Sure.
who actually,
Legendary on the island.
who this show actually is almost a continuation
Sure.
of her show that she
Right,
did.
it is.
And your organization is a continuation of what she started 20 years ago, 30 years ago,
Almost 40.
40 years ago.
Yeah. I started
Wow.
with her when I was a Boy Scout back in the 90s.
It's amazing.
And that was when it was the Alzheimer's Association of Staten Island, then it became the Alzheimer's Foundation of Staten Island. Unfortunately, she passed, and out of that organization, we still saw the need, and we started the Staten Island Agency here on the island. And she still leaves a lasting legacy here on the island, and she's helped, thousands of families over the years, and you still hear from them, and you still see them in the community, and that legacy will never go away.
I'll never forget the program. She asked me to run her medical board.
Oh, yeah,
And
yeah.
we had wonderful events all the time. And she'd say to me, Allan, people are getting this disease earlier and earlier.
They are.
And she'd say, I have a group that are meeting her in their 50s. And I'd say, well, you're Gladys, most people are over 65. The incidence is about 1% under the age of 65. It's a small number. She said, I'm seeing it. And she was so right. If you work in the community,
You see
you
it.
see things.
things.
You see younger people with it, people who are recognized more. Some treatments came out during her career and
Sure.
my career. And just to talk about some research with regard to Alzheimer's disease, we're coming up to some really exciting times. We've had medicines that have come out, a drug called Aricept or Exelon, which is a medicine that replaces a chemical in the brain that's depleted in people with Alzheimer's disease. But again, it's a partial therapeutic intervention. Then we have a medicine called Namenda, again, trying to deal with certain chemicals in the brain, but doesn't affect how the cells deteriorate. We're coming to a point right now where we're hopefully able, in the very near future, some medicines have shown some benefit called monoclonal antibodies and other kinds of treatments, where we shrink away the amyloid, or this plaque, this bubblegum-like plaque in the brain that causes the brain not to be able to communicate between its cells, between nerves, and one nerve and another nerve. Neurons. And when neurons or nerve cells don't communicate, things get blocked and you're not able to function at a high level. So we're coming up to, probably in the next 2 or 3 years, many, many new treatments. And those new treatments are going to revolutionize Alzheimer's patients, dementia patients. And what the goal of those, and what we've seen in the studies, is that when people are diagnosed early, they do better. We're even using some of these medicines before they're actually diagnosed. People with this mild cognitive impairment. When we wait too long, nothing works. In a sense, if someone has had 5 heart attacks or needs a lung transplant, there really is nothing that works at that point other than the transplant. Someone needs a new hip replacement. It doesn't matter how much exercise you get. There are things that happen. So we're really on a very cutting edge area, and Staten Island and the tri-state area is really heavily involved with that. I want to thank everyone for being here.
Thank you for
As
having
I
me.
told the gentleman, her first visit here was it's the fastest 30 minutes you'll ever have. And our other old pros here, they know about things.
Oh, sure.
So please, Brian, if you have 2 seconds, just mention how to reach you guys, and then we'll say goodnight to everyone.
They give us a call at 718-313-1420.
And Neshama,
Sure, 718-475-5228.
and that's the JCC of Staten Island.
Absolutely.
And you take people from off the island too,
Absolutely.
if they want to come out. So thank you all, and have a wonderful evening, and thank you to my wonderful, wonderful guests.
Thank you.